think maybe just two announcements, sort of things that I just want to mention. So that people might be wondering about. So information on final reports. I know we're coming up, on the end of the fiscal year here for programs. And but the information on that, on the final reports, is going to come out at the same time as the information for the regular Flex final report info. It'll just be like a separate page or along with it, but we'll send it all at the same time. And I think it's probably around September-ish. Okay, so it's not going to be right now. It might be a little sooner than that if we've got it all together. I have to talk with Laura to finalize and really be sure about that. But just be on the lookout for that once it comes. And then I know that there are lots of folks wondering about the next set of EMS supplements and when the NOAs will be sent out for those. That's going to be in August at some point. I don't have a specific date for that. It's not something that I have a whole lot of control over. But they do tend to drop in August, probably around the same time that the Flex NOAs will drop, I assume. So I just wanted to mention those two things. And of course, as you know, if there's anything that you want to talk about, discuss, ask a question on, something with your budget, something with your work plan, whatever it might be, always feel free to reach out. I am, generally around and happy to set up a call on the fly if we need. So, Caleb, I'll set it back up to you to set up the speakers, and I think that's it.
Thank you, Talia. Any questions before I will read our bios for our speakers, and Anusha's got a couple questions for us as we get started, but I'll give just an opportunity for questions for Talia or anybody else before we go. All right, so Laura Mispelon is the Social Drivers of Health Manager at the Michigan Center for Rural Health. She's got a bachelor's degree in applied science and a master's in healthcare administration. Was practicing as a dental hygienist for over 10 years before joining the Michigan Center for Rural Health. Passionate about health equity and is an advocate for health and well-being, especially for those who reside in rural communities. She believes strongly in the power of prevention and ensuring people have the resources they need to thrive. And I will introduce Matthew as well before we get started. Matt is a nationally recognized speaker and leader, having served the EMS industry for almost 2 decades, working in many diverse roles, including EMT, paramedic, flight paramedic, operations manager. He has managed and led successful teams in a variety of EMS disciplines in both rural and urban environments. Currently manages the National Wellness Program dedicated to improving the experience of first responder work, providing resources, education, crisis intervention, and outreach for the nation's largest EMS provider. So join me in thanking both Matt and Laura for speaking today, and welcome. Thanks.
Thank you. Well, I will be honest, when I heard and read through Matt's introduction, I thought, oh my goodness, I am very nervous to present with this fine guy. But I am excited to kind of provide a little bit of insight into the SDOH space. And then I'm really excited to also be able to pass it on to Matt, because I think he's going to be able to provide that lens that's specific to this space, and really be able to join these two kind of what's been said, like their own worlds together. And I will say too, I know that Patrick Fox is new to our team. So he's the new EMS programs manager. So he's on the call too. And I think it's interesting timing in the sense that this is his first week. And the first thing I said to him is he's like overwhelmed by everything. And so how can we bring these two worlds together in our plans? So one of those things that I know we're going to allow him to get his feet wet first, but it's an exciting space to be able to work in. So I wanted to first, and Matt, I have to apologize. I took a photo from you online and it's a bit blurry.
I'm kind of blurry in real life. That's okay.
I'm sorry about that. But I did just want to say, so for today, our goal is that I'm going to be able to provide kind of that SDOH lean, and really just touch on a few projects that we've done as a update office to kind of dive into this space. And then again, I'm excited to pass it over to Matt, who's really going to be able to connect those dots and really provide that lens that's specific to EMS. So this is not going to be new for you all. I feel like as we're talking about the social drivers of health, this is an area that we've touched on a lot, but I always think it's good to level set. So just so as we're looking at terminology and kind of what we think of when we look at this space, I think it's a good place for us to start. So when I started this 2 years ago, when I was looking at the social drivers of health definitions, it was overwhelming to say the least. And I feel like sometimes I would read a whole definition and I would say, what does that mean at the end of it? So I think for me, and what kind of helps me to work in this space is it really is those non-medical factors that influence health. So I like to explain my role and kind of working in the SDOH space is really being able to think outside of the four walls of either a clinic or a hospital and really start looking at the root causes. So as we're thinking about not just addressing kind of that current condition or why they came into the clinic or the hospital, how can we think a bit more upstream and be able to kind of think about those root causes of why things are occurring within our community. I also think when we think about the social drivers of health, it does force us to think of the whole person, right? When someone comes with a condition or some type of a specific concern, we tend to address that concern. And I think now we need to start thinking about the environment that they live in, the resources that they have, and really think about all of the factors that impact that person. And
Laura?
then, oh, I'm sorry. Yep.
Nope, that's okay. I just wanted to check, are there slides? Because you mentioned a fuzzy picture of Matt, but we don't see any slides.
It would probably help if I shared my screen, wouldn't
Okay.
it? Yeah, no, that's a great point. Yeah, that would be helpful. Let me go ahead and share my screen. Thank you. I appreciate it.
Oh, no worries.
Here we go. Well, now I'm going to have to show you the fuzzy photo so you can see what an awful job I did getting a picture of him. This is his. Yeah. All right, there you go. Thank you. And then the last thing I wanted to touch on with the SDOH space is I think it also, besides just thinking about the whole person, it makes us think about kind of the systems, the structures, and then all of those forces as well too. So again, when we're thinking about a person, what are all of the factors that influence their health? Health equity is also, I feel like, a word that comes up quite a bit when we talk about this space. And again, I like to keep it simple, and it really is an opportunity for everyone to be as healthy as possible. But when I say that, it is important to note that what is healthy for one person is different than the other. And so when we're thinking about health equity, it's that opportunity for them to attain their highest level of health. And that's what it looks like for them. Also important when we think about equity is that everybody faces their own unique challenges and barriers. So the resources that we provide, the resources that are available for them need to be tailored to what makes sense for them. Also, this kind of population health space, again, is a word I feel like is brought up often. And I think it's an opportunity for us to think about the health status and outcomes of groups, right? So if we're thinking about a specific region or we're thinking about a specific group that has a chronic condition, it just really helps us to understand kind of that population and that broad group. And then I feel like this is always kind of an elephant in the room, and you will probably guess what we use by my title is we do promote using the drivers of health instead of utilizing the word determinants, and we do that with intention. I would say it drives from, we know that the words that we use matter, right? But I also think that when we are thinking about that policy change and really thinking about the impact that these factors have on a person, it's not that the person has less control over their health. It should not be because of the area that they choose to live in. This should not determine their health and their quality of life. It unfortunately does drive it. So when we use the word drive, we're trying to hold those accountable that are really at that policy space. So how can we, be talking about this space in a way that it's not, well, this is just the way that it is, but we know that this is happening. How can we create change knowing that this drives it? So hopefully that makes a bit of sense, but we do want to make sure that we hold those accountable and make sure that we're not saying that individuals don't have control over their own health and their health outcomes. So I kind of touched briefly on the social drivers of health, but I did want to mention just a bit, especially when we're thinking about kind of these 5 buckets. So when we're looking at health, we're looking at the social drivers of health. We have economic stability, we have education access and quality, we have healthcare access and quality, neighborhood and built environment, and then we have that social and community context as well too. And thinking about kind of the drivers of health, this is not new. I would say since COVID, we have an increased awareness of it, and we've kind of seen it play out over the years. But I think it really is just that opportunity to identify that unfortunately right now the zip code and the places that we call home have a direct impact on our health and the quality of life as well too. So for anyone that has met me before or heard me present, I love data. I think it drives home a piece of the story. I don't think it's the whole story, but I think it's good to be aware of some of these facts. So I just wanted to go over a few things that I think really help, again, to help us understand what our communities look like. I will be honest that a lot of our data is Michigan based because that's where we are, where I am. So, but I think it does still put it into perspective. So when we look at economic stability, this is always interesting to me that 1 in 10 individuals that live in the US live in poverty. And then when we think about our state, so Michigan, 13% of those that live in our state fall below that poverty line. So when we think about that line, that is when we think about state assistance, any additional support that they can get, they need to be at or below that line. I also do like to mention in this space, and for those that don't know, this ALICE group, so it's asset limited, income constrained, employed. And in our state, we have 25.9% that fall into this space. And I bring this up because when we're looking at those that need support, often this ALICE group makes just above that line. So they don't get any support within the state, but they don't make enough to be able to meet those basic needs. So when we're looking at this group, it's often those individuals that have to make a decision each month. Are they going to be able to pay for rent, or are they going to be able to put food on the table? And so I think, again, it's that kind of understanding that when we're putting those 2 groups together for our state, we're at 39% of those that, kind of fall within this space. So again, I think it just brings a little bit of perspective onto it. And then when we're talking about kind of those poverty lines, I think it's interesting, and I always like to see how they change each year. And I just looked this up yesterday, but for our state, to fall within those lines, you have to make no more than $14,500. So in my mind, I always think about like what my monthly bills are, right? And you think about, that 14,000 for a whole year, and until you hit that point, you don't get state assistance or any extra support. So I do think it puts it into perspective a bit. Education access and quality. This one I find interesting. And again, I just pulled this up, and this is for our state in Michigan. I keep saying our state. I guess I'm referring to Patrick. But interesting enough, we know the education that we have directly impacts our health outcomes. So for the median annual wage in our state, if you do not have a high school diploma, the average wage is right around $12,000. For those that do have a high school diploma, we go up to about $20,000, and those that get a certificate or a bachelor's, it puts us up into $40,000. And so I think, as our state, at least, we're really trying to push that education piece. Not so much, I mean, if individuals want to get an associate's or a bachelor's, but also that piece, that certificates, and being able to have, a working, some type of kind of course, some type of path when it comes to that does increase kind of your health outcomes as well. And then for our state too, in Michigan, with the healthcare access and quality, again, always surprising to me, but we have about like 7.1% that still do not have insurance. And we know that that impacts those that are able to access that preventative care. The next one is the neighborhood and built environment. We know that where we live impacts our health. I think when we think about rural communities, we know that the housing market tends to be older. We know that there is an impact on the paint that was used in the houses, the way that the houses were built, the quality of the houses, the water, the air, all of those things play a role within our health. If you haven't yet too, there's one slide that I go into that is the county health rankings. And if you haven't had an opportunity to go onto their site, they do a nice job of looking at your state as a whole, but they also break it down per county. Again, loving that data aspect. One of my fun projects for the day was to be able to do the life expectancy per county throughout our state. And it's surprising to me because there's counties that live so close, that are so close in proximity to each other. And sometimes there'll be a 3 to 5 year age difference with that, within the length of life. So it's interesting, when you really start to see it as a whole photo. And then last, I just wanted to touch on that social and community context. I think, again, when we're thinking about our rural communities, we know that we tend to have a larger aging group that lives within our communities. And there's that social isolation piece that we need to be aware of. Those without that formal structure. So if they don't have support from family, they tend not to be able to access the resources and tend to be confined into their homes. So I did just want to create some awareness on that. This comes from the county health rankings. Again, if you haven't had a time to jump into it, I love it. I tend to use this often, but I think as a visual, it's just a good place to start. When we're looking at those non-medical factors, we know that all of these factors account for 80% of our health outcomes. So when we look on the right side, that clinical care, the access to care, that quality of care accounts for 20%, which is vitally important. And that is a huge part of the work that we do. But I think it's important to remember that these health behaviors, these social and economic factors, these physical environments that we live in, those account for 80%. And so as we're thinking about converging these two spaces, this is that why, right? Is that we need to be thinking again outside of that access to care, that quality of care, and just thinking about how all of these play a role into a patient's health outcomes. So this is like the why am I here, connecting those dots on my level, but then also passing it over to Matt that will be able to really dive into this a bit more. But we know that EMS is really well positioned to understand this space within their communities. One of the things that we're seeing is hospitals, clinics, we're now screening. So we're trying to understand those social needs, what patients need. And oftentimes they're gonna maybe list 1 or 2 of their highest needs, right? EMS, people that go into the homes, they see where they live, they understand that person. they're able to really understand those insecurities that maybe a patient doesn't bring up. One of the other things that I think is important to think about is when we're thinking about healthcare, again, it's confined within those four walls. But when we're thinking about access to food, transportation, housing, people that get to meet those where they are at and really see where they live and, you know, kind of those resources that they have, they're really able to get a better sense of the person as a whole. And then again, not new to anyone on this line, I imagine, but the community paramedicine space is something that we're excited about. I would love to say if there's a funding stream attached to it, because it would make it more exciting. But I think it's one of those things that we have to continue to push it because it really does connect those dots when we're thinking about the EMS and the social drivers of health. Again, not a newer model, but it's an expanded role. And it really kind of is able to bring that primary health care and public health to get together. It's also when we're thinking about that return on investment piece, although we don't have a designated funding source to it, I think if we're bringing, you know, less ED visits, more chronic care management, there's opportunities to kind of think again outside of that space and the value that they're able to bring. I did just want to touch on this, and I think when we're thinking about the social drivers of health, it can be a daunting topic because when we're thinking about food insecurity, we're thinking about housing, we're thinking about transportation, which is like the #1 thing that comes up in rural communities. It's not an easy fix, right? And when we're thinking about rural communities, we often tend to be resource poor, right? We just unfortunately do not have those resources that we need in our rural communities. But I think a really good place for us to start, and when we're thinking about EMS, they're so, again, well positioned to do this, is how are we connecting them to the community action agencies in our communities? When we're thinking about the local health departments, is there a connection that we can make there? For our state, 211 is a great resource of just kind of broad resources throughout our state. Do your EMS providers have a card that they can leave, you know, when they go on a call? And at least they're able to make some type of a connection. So again, I think we would all like to do these big, grand projects to help this space, but I think there's also just like a natural place for us to start as well. So 2 quick things I wanted to touch on that we are doing within our state is we were fortunate enough to get a HRSA grant. So it is called the UP Workforce Innovation Network. So we call it UP WIN. So this is a project that we are doing in the Upper Peninsula of Michigan. And really what we've been able to do is we've been able to do a collaboration with NMU, so the Northern Michigan University. We love our acronyms. And they have a Center for Rural Health up there. And our goal with this project was to increase access to healthcare within the UP. So 2 specific models that we were able to bring was the community health worker and then the community paramedicine. And really what we've been able to do was leverage this EMS space to address those that were at risk. We were able to really focus on these chronic conditions, being able to put the provider into the home. And then overall, our hope was to decrease hospital readmission rates. So that was kind of our goal. So we're trying to get those individuals in that community to understand these models and really want to be a part of it. Lastly, I did want to just note, and this is not new for our state, it really started in 2018, but there was a reason for us to really be aware of the need to be able to get the Narcan into communities. And so we have supported some of these efforts, especially when it comes to being aware that this exists. But for those like first responders that are part and on the scene for non-fatal overdose, it's one of those encouragements that how can we leave this? How can we embed this into the community? And so that is one thing that we have also been a part of as well. So that is it for me. I am excited to pass it on to Matt. I know he's going to open the floor. He doesn't need slides like me. He's going to open it up to discussion. So Matt, it's all you.
Thanks, Laura. And
Yeah.
thanks for just teeing that up perfectly, because you kind of led into a part of the conversation that I'm really passionate about, and that's the kind of looking at this concept through the EMS lens. And one of the things I'll say, I truly find power in conversations like this, especially when there's conversation and passion and disagreement. So for anyone that's on the call that goes, hold on, Matt, I don't really understand what you're saying, or I disagree with what you're saying. I love conversations like that, because I think if one person's feeling that, then others are as well. So I would encourage you to please don't hesitate to unmute and let's engage in that conversation. For me, I agree. I believe what Laura said about EMS being well positioned to really impact, and I'll say continue to impact those drivers of health, is an understatement. We are a diverse workforce that can build trust in 30 seconds or less. If you look at the work that EMTs and paramedics and flight paramedics and flight nurses and other members of the EMS community, dispatchers and fire departments and law enforcement personnel, we build trust with complete strangers, and we convince them to let us poke them with sharp things in the back of a moving vehicle. So we have this innate ability to foster connection almost immediately. And we do that through all of these kind of these really special components. Kind of look at it through the lens of leadership, it's emotional intelligence, and it's empathy, and it's creating a safe space for individuals. And EMS as an industry, we're incredible at that. And I'll say that most of our industry looks at this concept as this frontier, this new and innovative frontier. But I'll also say we've been doing this for a really long time. We just didn't have the terminology for it. So I look back 20 years ago in my career, and I think about the hypoglycemic patients that would go unconscious in their house, and a loved one would call 911. And then as the frontline paramedic, I'd respond, and we give them some glucose. And then we have this opportunity to impact one of those drivers of change. And what that looked like in the moment was, I can leave this person and just encourage them to go have a healthy meal that's high in complex carbohydrates, so that they could not have a decrease in their blood glucose again. Or I could be the person who stays there and makes that meal and does an evaluation of what's in their fridge and opens the cabinets and then creates, something for them to eat, and then maybe creates a backup meal a couple hours later, and then gives them the information that they need to kind of, essentially prohibit this from happening again. So as an industry, we've been doing that for a really long time. And I'll say, collectively, we look at opportunities for that sort of spark of change. We've been doing that for decades. We just don't have the lens that Laura really eloquently described in the current state. And why does that get confusing for us? For me, I say that our industry, when we get hit with concepts like cultural competency or innovation, the one thing that EMS is really uncomfortable with is change. The other thing that we're really uncomfortable with is the way things are. So no matter what, we're unhappy as an industry, but we know that it can be better. And so when we look at what it takes to make the system as a whole better, there's EMS agencies across the country that are doing this really well. They leverage innovation, and then they leverage leadership. They leverage those relationships that leaders make within their communities, and whatever that community looks like. So cultural competency kind of fits into that. For me, certainly fits into that holistic approach. So when I describe the concept of cultural competency, there's certainly a DEI and B lens that could be viewed through, but it's understanding the culture that you're a part of and understanding the culture that you're serving. And that may change from a call by call moment. So I looked around the audience members, and I see that there are people kind of across the country. And I live here in the state of Oregon, and we have a large tribal population. I should know that if I'm going to serve a tribal population, there's a specific nuance, there's specific cultural heritage of the people that I intend to serve. And so looking at not only how do I show up to them, how am I viewed to the people that I serve, how do they view me, how do I view myself in this relationship, and how do they view themselves in this relationship? So there's these 4 distinct lenses that just that one simple conversation can be viewed through. But really understanding where you fit into that complex dynamic of a cultural relationship, just the understanding of that fosters connection, fosters empathy, fosters an increase in emotional intelligence, and ultimately drives really positive outcomes. So I'll get really specific here for a second. One of the things that I do with my current role is I respond to crisis and catastrophic events. And so I go to airplane crashes and employee deaths and suicides and things like that. And I'm often thrown into high stress situations, having never met the audience before in my life. And so about 2.5 years ago, I deployed to Hawaii for a fatality. And I was working with the frontline crew, and I wanted to approach with this sense of cultural competency. And if you knew me, you'd see that I'm 6'3", very pale, living in the Pacific Northwest. I don't look like a native Hawaiian islander. I don't fit that native culture. And so in order for me to build trust right away, I just called it out there. I said, hey, you might not be able to tell from looking at me, I'm not from around here. I didn't get the memo that I was supposed to show up in board shorts and flip-flops, and I was wearing like waterproof pants and banners, which is a very Pacific Northwest thing to do. But in that moment, I recognized the nuance and the specialness of that deep cultural heritage that I was a guest in. And so if EMS can really leverage that, and there's all these different cultures and these different populations, but if we could leverage that, that's really kind of our ticket to moving forward in a really positive direction. And then I also think about, what does that look like from EMS on a tactical level? And so I said earlier that there are agencies out there that are doing this really well. And I'll use kind of this case study from the community paramedic or the mobile integrated healthcare perspective, because I think that's a hot topic and it deserves attention. And all of these concepts that we're describing can be scaled down to the microeconomic level, all the way up to the macro, which would be huge populations, urban areas, tens of thousands of transports a month, all the way down to the rural agencies which I have a true passion for, which might be 5 transports a month. But each one of those interactions is an opportunity to really increase EMS's presence in the healthcare community and within the health of the populations that we serve. And so one of the agencies that I'm thinking of is in Southern Oregon. They're a medium-sized EMS agency. And about 7 years ago, they wanted to get into the mobile integrated healthcare or community paramedic space. The initial thought was, let's reduce readmission for ortho-related surgery. So they specifically looked at hips and hip replacements. And they said, if we can impact the readmission rates for people who got new hips, then we not only improve the population, the health of our population, we reduce the readmission rates, we improve the relationship with the local hospital systems. That's the way we want to go. So they do that, and then they have a moderate impact. They did risk assessments for falls. They went to patients' houses. They did teleconference follow-ups with the orthopedic surgeon, so it reduced wait times in clinics and things like that, and had a moderate impact. But that's not really what the community needed. And if you fast forward 3 to 5 years later, that same mobile integrated healthcare team transitioned into looking at one of what Laura mentioned, one of the social drivers of health is houselessness or homelessness. And so there's a significant homeless population in the community that they were serving. That population utilized EMS services at a much higher rate than the housed population. And they said, okay, so from a proactive approach, let's look at what this community is activating EMS services for, and then let's attempt to impact that in a positive way by reducing the use of the overutilization of the 911 system. And you say, that's great, but what are the tangible things, Matt? What did we actually get out of that? What we saw and I was living and working in this community at the time, what we saw is that there was a reduction of inappropriate 911 utilization, which reduced the number of transports to the local hospital systems, which reduced ED overcrowding, which reduced the funneling of boarding issues that the local hospitals were seeing. It increased throughput, which at the time was this buzzword for EDs. And we saw all these downstream effects from this organic growth of looking at a specific population. Now that can be done with populations of all sizes. And so I think from the rural perspective, what does that really look like? And that's very unique. So unfortunately, I can't say to this group, hey, here's the one thing you should do and make it all better. There's just no singular answer for that. And so that true evaluation of what your community needs are, where you think you can maximize that impact, that's really the secret sauce. That comes from kind of another passion of mine, which is this true sense of growing innovative leaders. And so I'll just share this. I get called into lots of conferences and lots of conversations, and I speak across the country with the work that I do at SafeTech. I will say that conversations like this rarely happen. So this group is already 95% of the way there. You're already having this conversation. You're tackling these complex issues. You're engaging in conversations surrounding it. I can't begin to tell you how incredibly unique that is. So I want to pause because, like, in a true sense of admiration, I love that this is happening. And I was really excited. I know that you probably think I'm totally full of it, but I was actually really excited to come talk to this group today because this is so outside of the norm of the kind of the normal conversations that we're having. So I have said a lot, and as you can tell, I get very excited about this kind of stuff, but I will pause. I would imagine there's comments or disagreement or questions, but I want to make a point to deliberately pause because I'm very conscious of the time.
I want to provide the opportunity for questions, but as people are developing their questions, please put them in the chat box, unmute yourselves, and let us know what questions you have as we relate to these. To both Laura and Matt. I had a question, Matt, about I'm thinking of strategic planning. If we've got a, whatever small or mid-size EMS agency connected or not to a hospital, and we're talking about developing a community paramedicine program to reduce falls as maybe our initial pilot project, and then out from there, in my estimation, we need to have considered these things, and developing a community paramedicine project shouldn't be done lightly or I'm thinking of that as like standing up a service line at a hospital. You don't want to implement a cardiac rehab project if what you have is 4 times the rate of diabetes in your community and no cardiac issues. You don't, especially for our audience of rural, under-resourced agencies. How do you, is that happening at the rate in which it should, so we're not overextending in such a way? How do you develop just an open idea to, maybe it isn't community paramedicine. Maybe it's this other home intervention and support within the connected or not hospital, whatever it is. Is that done in such a way? Is there an opportunity there? What's the appreciation for the strategic direction of an endeavor like this, and then making sure that's kind of followed for a couple of years, and then we can realize, no, it's not a falls related effort that we need to implement. It's something related to this.
Yeah, so huge question. And it instantly made me think of like at least 3 very different ways that I would answer it. And so when I say it's a difficult question, our industry as a whole, if you collectively look at EMS, unfortunately, we're not leveraging the idea of innovation in a way. In concept, we are. In practice, we are not. And so for any of you that might be familiar with the ET3 concept, ET3 was a concept which very simply was an alternate destination concept. So meaning if someone calls 911, can we transport them to a more appropriate destination other than the emergency department? And there were pilot programs all over the country. This was led by CMS through the Department of Innovation with CMS. And the program was ended early. And the program was ended, or the pilot program was ended early because of a lack of participation. And that's an oversimplification. There's a lot of nuance and specifics with that. But generally speaking, it ended early because there was just a lack of participation, and there was a lack of data collection that was being done by the agencies that were piloting this program. In concept, a wonderful idea. So saying, hey, if I call 911 and I'm not having a true medical emergency, but let's say I broke my ankle and I can't physically drive, I don't necessarily need to go to the emergency room. I probably need an urgent or immediate care. And our industry, our system is not designed to allow for that to happen. Ambulances by statute can't transport to alternate destinations. So it's this huge paradigm shift in a direction of saying, what if we just transported people to a better place than the ED? And so we grasp the concept. We know that something has to change. Unfortunately, the barriers that exist feel insurmountable. And so that's happening on an industry-wide level. And I truly believe if we fast forward 20 years from now, we're going to see alternate destination. We're going to see treat and release. We're going to see nurse navigation. These will be parts of our EMS system that will feel innovative now. They'll be built into the structure of healthy EMS systems moving forward. What I'll say is that we don't need that industry-wide innovation to really spark true community change. And so I'll use an example of someone who's a kind of an EMS sage, a gentleman by the name of Mike Tagman. Mike is an incredible human being. He's a long history in EMS. He speaks nationally to EMS. He's just a champion of provider wellness. Early in his career, he was the operations manager or general manager of the Oakland division of an ambulance service. And what he found is two very specific things. He found that the African-American population in Oakland had a hesitancy at the time, and this is in the early 90s, I believe, of utilizing the EMS system that was in place. And so you had a specific community that had, for whatever reason, a cognitive barrier or a physical barrier to utilizing the EMS system that was in place. And so you saw a decrease in a specific population's health. When he looked at the data surrounding it, he found that there was a higher rate of hypertension specifically with that community. And if they were able to impact that or create an opportunity for that specific community to have access to medications or resources or evaluations or screenings related to hypertension, they could positively impact the health of their community. So what he did is he fully immersed himself into that community and said, okay, where is the access point for our people to build a relationship outside of the stress of a 911 call? And so he looked at community churches and he found that, okay, if we leverage our presence at a church and we say, hey, we're going to do a free blood pressure screening at the end of Sunday Mass with, in particular neighborhoods that maybe were relatively underserved, medically underserved, that is. And he said, if we target those neighborhoods and we target this community specifically, we can positively impact the population health. That wasn't from anyone else out there doing that. That was just a guy with this beautiful North Star of, I want to help the community I live in. And so there are opportunities like that in all of our systems. But what it takes is people to look at their communities through the lens of what are our specific needs, what's the risk assessment, what are the KPIs if you want to get really managementy, and yes, I completely made that word up, but what are the KPIs that we can look at to then say, okay, what dials can we actually turn in our communities to really impact our community health? So I'm optimistic where our industry will go. I'm excited about where it will go. I'm also impatient because I wish we were there 10 years ago.
So I've got a question for you around working in the SDOH space. Can you talk a little bit about data collection and reporting and how you actually, get the information that you need consistently from all the agencies that you're working with in rural areas? because that's a really difficult task.
And I also fully recognize that I am part of a minority population that really gets excited about the idea of data collection. And I know that when I bring up the concepts of data collection to specific audiences, I can literally watch the passion drain from their face. So I truly believe that data is one of those things that we can leverage to help with the storytelling component. And so when I talk about data and the power of data collection, we're getting the data. The avenues to collect the data exist, but the interpretation of the data and the storytelling component behind the data is really what I think is what the people that are doing it really well, that's what they focus on. And so I referenced the agency in Southern Oregon that was looking to kind of impact 911 transport volume or overutilization of the 911 system. So what they did is they let's look at all of the transports we have. Now, the data collection at that time for that agency was barbaric. It was, we have one system and all of the calls go through it, and we have built-in avenues where we push through the data to the state level so that it's populated. For us, it was EMS, but in the NEMSIS system. But there wasn't any sort of reflection component. So we collected all the data, and then we ranked patient names or date of births or have a specific qualifier to then rank the number of times that person called 911 in the previous 90 days. We just did a 90-day look back, and we said, is Matt Philbrick calling 911 at a higher rate than anyone else in the community? Yeah, he called 911 10 times in the last 90 days. He's going to be someone that we target to say, hey, what are your specific needs? Why are you calling 911? What do you need from us? And sometimes they were mental health related issues. Sometimes they were social issues. Sometimes there were issues just related, like I couldn't get my prescription filled and I didn't know who else to call. But it took our agency at the time to then target those people and then be proactive in that outreach. Where data collection has grown and what's really exciting for me is there's forecasting components, and there are people out there that are experts at this, and it is fascinating the work that they can do from data. What I really get excited about with data is that it lends to increases in not only patient safety, but patient outcomes. And so one of the kind of the industry leaders for this concept is a woman by the name of Krista Haugen. She's the National Patient Safety Director for Global Medical Response. And she's really looking at how can we look at specific instances? What can we do? What not only what policy and procedure changes do we need to look at, but how do we look at the care that people are providing to forecast patient safety outcomes and ideally positive patient safety outcomes. Where I think the starting point is just recognizing what data systems we have in place. So if you're an EMS agency and you're transporting in the United States, you have an obligation to be NEMSIS, I think 3.5 compliant at this point. I forget the decimals. I don't know if it's 3.4 or 3.5, but you're required to be NEMSIS compliant, meaning you're pushing specific chart related data up into a national EMS management system or data management system. So we're already doing that, but we just need to figure out what that is. And then kind of the next step is, what are the agencies around us using? So all of that data and those specific data points are going to some sort of state or national database. How do we then take that data and then look at whatever our KPIs are? What is the dashboard that we think is really appropriate? Now, it's not up to me to determine that. So it might be on a really basic level. If you're looking for operation system performance management, it might be, what are our shoot times? What are our response times? What are our transport times? What are our clearing times at the hospital? Those are just some really, that's one set of data that you could look at to just kind of look at efficiency of your EMS system. And the storytelling component, and why I get excited about that, is, let's say your average response time is 34 minutes. And I just made that number up. But there's no part of your community that takes 34 minutes to drive to. And you're like wondering, okay, well, why is that happening? Well, the storytelling component is, well, we're relatively understaffed. And so we're a volunteer agency calling in people from home. So we interrupt people in their personal lives, and it only takes 34 minutes for them to get here and respond to that call. That's amazing. So depending on what lens you look at it through, the data can be used to kind of amplify the positive story, and hopefully the positive story that you're trying to tell. Long-winded answer. I feel like I went into an area that you didn't even ask.
No, that's fine. I think that was, you know, a really nice kind of overview of some of the ways that you can get to the data, how you can use the data. I think that it's also sometimes can be difficult that once you like find that project, right? You've gone through the data, you have your population, you know who you want to target, collecting that data to show the impact, to prove that it's worth doing, to get it funded, you know, to like get through all of those things to try to help that impact piece. I think that can be difficult too, because it's like a lot of times might be something new that they haven't been collecting before, or, you know, it's one more thing that they have to do, and making that case for the importance of it can be tough sometimes.
So I love that you said that, and really that's where leadership comes in. So when I think of how do you do that, how do you take that very specific thing and leverage it? People make decisions, especially financial decisions, with emotions, not with logic. And so if you can leverage, like logically, I should never buy a boat, but I'll tell you, when I buy a boat, it's going to be because like the emotional part of my brain tells me I need to do that. So we make those decisions with emotions, and what I think you can do is you can use the data to amplify the positive emotional leverage that you can have from let's just be honest, doing the right thing. It feels really good to do the right thing. And if you go to your stakeholders and say, you know what, we may not get data from this for 10 years. We may not know if this singular action that we took as an agency or a healthcare facility, we don't know if that really had a tangible impact yet, but you know what? It was the right thing to do. And we know it's the right thing to do because these people said so. Here's the personal testimonial. That's not data. That's just you leveraging what I think is the positive traits of transformational leadership.
One of the things I did just want to mention, and I think again, as we're hearing about more, you know, screening for the SDOHs, and a lot of the thing is that we're hearing is, so I screen, but we don't have the resources in our community. So now I'm screening, or I'm asking these questions, or now I'm identifying a need, but I have no resources to give them. And one of the things that I have really been pushing the awareness in is by you identifying that that need isn't met, and we're collecting that data to show in this community, we have no housing in this community. So I think although it feels like we're collecting it just to collect it, I think there's a greater need to get an understanding when we're looking at our rural communities. Where do we need more of these resources? So in that moment, it might not feel like we're doing much and I just identifying a need that we can't meet. But if we look at it as a whole, then how are we using that data to push that up to policy to say, we need more of this in our community? So I did just want to note on that too.
Yeah, no, that's great.
Yeah, I think Anusha, do we have some additional questions on the exit? But I want to make sure we provide time and opportunity. No questions on the exit. Sweet. What other questions do we have from the group? John, Jody, Josh, what other J names do I have? Jen?
Everybody's been very quiet today.
You know, I've got a
Go ahead,
comment.
Donnie. Thank you.
Yeah, I've got a comment. Data
Oh.
side.
Okay, Donnie and then John.
So one of the things on the data side that we found, and let's take the Narcan initiative, where we're providing, like in New Mexico, you could probably go into Walmart and buy Narcan, and you know, people utilize that. So a while back, we got a EPRA request for how many times do paramedics administer ketamine for agitated individuals and then end up having to intubate them. So we actually did that, and we found out there was only about 2 situations, which led us to another thing. how many people pre-EMS received Narcan, where whenever EMS arrives on the scene, now they've got an agitated patient. Now they have to administer a benzodiazepine, ketamine, or some other chemical restraint in order to transport the patient to the hospital. So to me, that's where data kind of plays into it. You can look at any initiative you want, but what does that initiative lead to? And by collecting the data on that, then you could actually go and look at the true benefits of Walmart selling Narcan. And that's the kind of things that we look at. So
drill down a little bit, focus on the issue, to Matt's point about falls compared to something else.
I love that. Yeah, Tony, that's a great point. Really, what you're doing is you're just narrowing the bullseye. You're eliminating all the noise, so you can really, laser focus on the thing that you're trying to address. I love that.
Yeah, and I was just gonna say, a lot of this just ties into some of the stuff that we're already looking at in Washington State. It's projects. Talking about identifying. You talk about MIH programs. Again, Washington is largely a fire-based EMS systems in our state, and that's exactly what one of our departments did here a couple of years ago. They had been wanting to do more MIH, and they weren't getting any headway. And of course, then COVID happened. But they were at a point where they were getting a call volume that increased to the point where they were going to have to add another ALS truck, which we know is, 1.1, 1.2, $1.3 million to do. And he said, well, what's our actual call volume increase? And the call volume increase were for patients who didn't even really need a BLS ambulance, let alone an ALS ambulance. So they actually spend now, I think he said his last budget was about $300,000, so a quarter of what putting on an ALS truck would be. But they fund a full-time PA, a full-time community consultant. I can't remember what their exact title is, that goes in and does those home health visits, and they build wheelchair ramps, and then the PA can actually go to people's houses and actually do prescriptions or recommend. They're doing ultrasound, and they just brought on a part-time behavioral health professional, an actual licensed behavioral health person, and the community is actually getting the care that they need and deserve. It costs less, and has said for the first time since he's been a chief, since he was 19 years old, their call volume has actually gone down. But again, they're providing the service that's needed, not another revolving door.
And you said a third of the initial expected cost. That would have been super tough. That's a great example, Sean.
Yeah. So
again, if you don't know the data, you're going to you think you have more calls, so you need more trucks.
Yep, and that's what they did. The volume was there, but that wasn't the what they were transporting or why they were transporting. If you just looked at one component of calls are up, yep, more trucks, let's make some more circles. But they said what types of calls were up.
Yeah, are they transports? Are they high need? Are they traumas? Is it? And if it's, I can't get my medication refilled, or I can't get out of my house to my appointment, so come and drive me to the ER.
Yeah,
because I missed my appointment.
Yep.
Big difference.
Yeah. So they actually came and presented for us at our National Rural Health Northwest Rural Health Conference here in Spokane in March, and we've had them present to a couple of our groups in our state to try to again get that word out of why data is important.
Yeah, that's a great example, John. Thank you. We are at the end of time. I've got a handful of minutes open at the end of this if anybody wants to stay around and continue the conversation. As Matt said, I really do appreciate the things that come out of the conversations. That's the benefit oftentimes of these meetings. I'd like to thank both Matt and Laura for agreeing to participate and present and discuss some of the benefits and things they have going on out there in the world, as well as everybody else who took the time to participate in the call. Anything else?
Everybody.
Thanks, guys. Well, have a nice day, and careful with all the storms. Apparently they're building.
Thank you.
Thank you.
Thank you.